Today I'll be discussing fracture care in the emergency department with you. Fracture care is probably one of the most unbilled procedures in the emergency room other than critical care. This is most likely, I think, because so many feel they do not meet the requirements to bill fracture care without manipulation in the ED. There's three types of fracture care. You have palliative care, restorative care, and definitive care. Palliative care, by definition, is an approach to health care that is concerned primarily with attending to the physical and emotional comfort rather than effecting a cure. Definitive care is the completion of recommended treatment. Restorative care is a remedy that aids in restoring health. We're also going to go over splints, modifiers, and RVUs. An example of palliative care would be the ER physician finds a fracture on the x-ray for a patient. He or she consults ortho and determines that the patient should be seen right away. The ER physician applies a splint and tells the patient to contact the ortho physician first thing in the morning. This is palliative care because we are just providing comfort for the patient until they can see a specialist for further treatment. Restorative care example, a 70-year-old female presents after a fall on an outstretched arm. An x-ray was performed which showed a dorsally displaced distal radius fracture. The emergency room physician performs a hematoma block and reduces the fracture. In this case, the physician provided restorative care because he or she actually performed a manipulation. So for this case, you would report the CPT code 25605, which is closed treatment with manipulation of a distal radius fracture. Emergency physicians provide important and meaningful fracture care on a regular basis. Although a lot of myth and mystery surround the reporting of fracture care services in the ED, there's a few simple concepts that can help greatly simplify things. In order to report fracture care services in the emergency department, the emergency physician must either manipulate the bones, which is restorative care, or for those fractures where manipulation is not clinically indicated, they must provide the same treatment that a specialist would provide for the fracture. This is called definitive care. If we look at some of the RVUs for fracture care codes with manipulation, you can see finger fractures carry an RVU of like 9.11, ankle fractures 12.82, and wrist fractures 15.44. Some of the most common fracture codes that the emergency department physicians see that require manipulation would be for fractures such as finger fractures, toes, metacarpal, metatarsal, distal fibula fractures, ankle fractures, and distal radius fractures. The physicians need to always remember to write a procedure note when performing these manipulations so that the coder can always make sure to capture these high RVU procedures. A definitive care example would be a 28-year-old male slips in the bathroom, striking the right side of his chest on the edge of the tub. The emergency room physician does an x-ray and determines that there's a non-displaced fractures of ribs 7 and 8. The emergency room physician treats the patient's pain, reviews all of the symptoms, the healing process, potential for complications, and orders a spirometer to prevent secondary pneumonia. The patient is ultimately discharged and sent home with a prescription for pain medication. In this case, the emergency room physician did not perform any type of manipulations of the bones, so it would be inappropriate to bill a fracture care code with manipulation. However, the emergency room physician in this case did provide the same care that a specialist would have given this patient, which means the emergency room physician did provide definitive care in this situation. So for this case, you would bill CPT code 21800 with 2 units for the closed treatment of the rib fractures. But you would also bill a 54 modifier because the ER physician is not providing any follow-up care. Another example of definitive care would be a 7-year-old presents to the ED with arm pain after falling on a trampoline. The emergency room physician performs an x-ray. It shows that the patient has a non-displaced and minor impacted fracture of the proximal radial head. The physician applies himself a short arm splint and a sling. The ED physician tells the patient to continue wearing the splint for the next 3 to 4 weeks. This is definitive care because, again, the ED physician provided all of the care that was needed for this injury. Some of the fracture codes that we use in the emergency department quite often without manipulation carry high RVUs as well. For instance, finger fractures have RVUs of 5.58, toe fractures 3.82, clavicle 6.71, and rib fractures 3.57. The most common, again, fractures that are seen in the ED without manipulation would be for fractures such as finger fractures, toe fractures, clavicle fractures, and rib fractures. These are high RVU procedures and should not be overlooked when performed by the emergency department physician. Sometimes people wonder if they can bill an E&M service with fracture care codes. Fractures are generally the result of a high energy injury, and they warrant a thorough evaluation of the mechanism of injury, the distal neurovascular status, and a screening for other injuries. As such, an E&M would typically apply. The physicians need to make sure that they document a thorough evaluation and management note. These cases also typically involve a prescription drug therapy and tend to be high-level cases. Often, they may be a level 4, 99284, or above. Splinting with fracture care. The indication for a splint is simply that you need temporary immobilization to improve pain and discomfort, or to reduce any further neurovascular injury associated with things such as fractures, sprains, dislocations, deep lacerations, and painful joints associated with inflammatory disorders. But if the fracture care code is being reported, then a separate splint code should not be added. However, if the ED physician applies a splint but does not meet the requirements for definitive or restorative fracture care, then the splint code would be reported. For instance, if the patient has a non-displaced distal radius fracture, which is placed in a short arm splint while in the emergency room, and the ED physician states that the patient's going to follow up with the orthopedic in a couple of days to have a cast placed, then the splint code should be reported and not a fracture care code. Keep in mind when reporting splint codes, the appropriate documentation guidelines must also be met. For some carriers, the attending must apply the splint themselves in order to bill, and for others, the attending only needs to check for proper alignment and note it in the medical record. So you would need to check with your carriers to see which rule applies to them. The documentation that should be included in the medical record when billing for a splint should be the following. We will always need to know the indication for the splint. The physician would need to describe any wounds and their location under the splint. Document the neurovascular exam findings. describe the type of splint applied, the area immobilized, and the materials used to make the splint, and the physician should always indicate what follow-up is needed. The common splinting procedures performed by the emergency department physicians are finger splints, short arm, short leg, and long leg. When billing for fracture care in the emergency department, there's 3 main modifiers that will be used. For many fractures, the follow-up care will likely be provided by the orthopedic and not the emergency room physician, which means when billing fracture care codes without manipulation in the emergency department, we would need to add a modifier 54 to the fracture care code. This shows that the ED physician provided the preoperative and operative care but will not be doing the follow-up care. With the placement of the 54 modifier on the fracture care code, the ED physician generally will receive about 70% of the revenue associated with that fracture care service. Since the fracture care code represents Medicare's major procedures with a 90-day global, the 57 modifier should be appended to any evaluation and management code that's billed for any Medicare patients. Some commercial carriers will take the 57 modifiers and others prefer the 25. So again, you will have to check with your local carriers to see which modifier they prefer. A 25-year-old crashes his bicycle. He suffers no loss of consciousness or neck injury and presents complaining of shoulder pain and road rash. Following a full exam and x-rays, the ED physician finds that the patient has suffered a clavicle fracture. The physician prescribes pain medication, discusses the progression of healing and the options for orthopedic surgery and follow-up, and any signs and symptoms for the patient to monitor. The patient is then discharged home with a sling. The following codes for this case are assigned. An evaluation and management code of a level 4, which is 99284, which carries RVU value of 3.37, and 23500 with a 54 modifier, again showing that we are not going to be doing any follow-up care, for a clavicle fracture, which carries an additional RVU value of 6.71. Definitive care can involve treatment of the pain, provision of discharge instructions, and in some specific cases, stabilization of the injury. If the patient has a finger fracture and the definitive care that would be provided by the orthopedist is placement of a finger splint, then in that specific case, placement of the splint may represent definitive care and be reported with the fracture care code. However, if the orthopedic would normally place a cast, such as for a distal fibular fracture, but only a splint was placed in the emergency department, you would not bill fracture care codes. Some frequently asked questions regarding fracture care. If I sedate the patient to reduce a fracture or perform moderate conscious sedation, should I report the fracture care codes that carry the term with anesthesia? Although the CPT manual itself does not have a specific description of when to apply the with anesthesia codes, written correspondence from the AMA personnel has stated that with anesthesia refers to procedures performed in the operating room. The additional significant RVUs applied to the codes carry the term with anesthesia reflect the extra effort involved in the formal OR process, such as standby time for OR preparation, scrubbing, the induction of anesthesia, and other OR processes. Can you bill for an x-ray reading if you're also providing the fracture care? Yes, you can, as long as you have met the documentation requirements for the x-ray reading service. There's no reason why you can't bill the x-ray along with the fracture care. CPT specifically lists the subcomponents that are considered bundled with surgical procedures, which are local infiltration, metacarpal digital blocks. Radiological services are not listed as being bundled. Is there a difference from a coding perspective between open and closed fracture treatment? Absolutely. Open treatment of a fracture describes a process where a surgical incision is made to reveal the fractured bones as part of the treatment process. Closed treatment, which is more commonly provided in the emergency department, does not involve making a surgical incision. The confusion arises in the treatment of an open fracture. Even if the patient has suffered an open fracture, the open fracture codes are only employed if the physician makes a formal incision as part of the treatment process. This would be the same as when a physician states that a patient has a complex laceration. That doesn't always mean that you would bill a complex laceration repair. If the physician's documentation doesn't clarify the type of treatment rendered, you always default to the closed treatment option. A typical case would be the physician doesn't further open the site where the open break occurred and doesn't need to do any internal repair, but instead simply manipulates the bones back into place, reducing the dislocation and possibly closing the wound. You would report closed treatment for this open fracture. ASAP describes open treatment as involving a surgical incision to expose the fracture for direct visualization. According to ASAP, an emergency physician usually provides closed treatment only, even when caring for an open fracture. Can emergency room physicians code for fracture care where no manipulation is required? Yes, according to ASAP, the emergency physician's overall management should be compared to that provided by other physicians performing the same service. For example, exclude complications, treat the pain, provide patient education, stabilization where appropriate, and follow up as needed, and take into account the patient's relevant circumstances. Of course, if the emergency physician does not expect to provide the follow-up care, then a 54 modifier should be appended to the code. Follow-up time must always be considered in billing fracture care. If the ED physician provides definitive care and tells the patient to follow up with his or her primary care physician or to follow up with a specialist in 5 days or greater, the coder could safely bill fracture care without manipulation with a 54 modifier. The reason is, if the patient can wait this long for follow-up and not definitive care, then the ED physician did provide the initial definitive care. On the other hand, if the ED physician provides palliative care or tells the patient to follow up with ortho right away, or if you see in the medical record that the ED physician consulted ortho or made the appointment for the patient, then you would not bill for fracture care. Also keep this in mind. If the patient follows up with a specialist, the specialist should be appending the 55 modifier, which states postoperative management on their claim. If for some reason the specialist does not use the 55 modifier, then most likely the insurance company is probably going to pay whichever claim gets to them first. So always make sure to report your claims as soon as possible. What if you have multiple diagnoses with fractures? Which diagnosis code should you list as primary? You should report any fractures that are open or complicated. If you have multiple fractures that fall in the same category, then you code the largest bone first. For example, report the femur bone fracture before an ulna bone fracture, unless the ulna bone fracture is open or complicated by debris. What's the difference between the terms often found in fracture care documentation without stabilization and with manipulation? Without stabilization means the physician simply provided palliative care. With manipulation means the physician needed to reduce the injury, which means he reduced the fracture or provided restorative care. Basically, without stabilization means you do not bill fracture care. With manipulation and without manipulation could indicate that you bill fracture care. What exactly should the physician document in the medical record for fractures? A physician should never simply state fracture. The physician should be as specific as possible. The physician should describe whether the injury is open or closed, what type of fracture, the degree of deformity, and distal, neurovascular, cardiovascular status, as well as the functional status of the limb. This is going to be especially important when ICD-10 comes. The physician also needs to state exactly what treatment was provided, whether it was open or closed treatment, whether or not he did manipulation or reduction, was it with or without anesthesia, was it with or without casting, splinting, or strapping. The physician also needs to state whether or not the reduction was successful and when the patient should receive follow-up care. The fracture care note is very important for the coders because this is how they're going to determine if the ED physician provided the initial fracture care management or if he or she is expecting the specialist to do so. A few tips to remember when deciding to bill fracture care. The type of fracture does not always correlate with the type of treatment provided by the physician. Like we had mentioned before, just because the patient has an open fracture doesn't mean we provided open fracture treatment. You always need as much detail as possible about the fracture, the site, whether or not it's a fracture or a dislocation, and you need the entire treatment provided by the physician. In conclusion, fracture care codes carry high RVUs and should not be missed in the emergency department. You need to know the proper documentation requirements and educate your physicians. If all the documentation is in the medical record, you need to make sure all your fracture care codes are being captured, whether it's with manipulation or without manipulation. Thank you.